Kevin Rudd promised a big shake-up in health before the last election, and the Reform Commission he established to review the entire system seems to have taken him at his word, perhaps more than he'd anticipated. There are a number of radical proposals across the health landscape in the Commission's interim report released today, including one option that would transfer control of the entire health system to Canberra, with public hospitals run by regional authorities. Another proposal would give the Commonwealth responsibility for a universal dental care system, which would involve a tax levy similar to the current levy that funds Medicare. The Commission also floats the idea of the Commonwealth taking over all primary healthcare policy and funding. The Commonwealth would also encourage the widespread establishment of new comprehensive primary healthcare centres, even bigger than the current Rudd plan for medical supercentres. To flesh out some of the reform proposals, I spoke late today with Dr Christine Bennett, who heads the National Health and Hospitals Reform Commission. Christine Bennett, the most obvious problems in the Australian health system relate to public hospitals, but you say many of the solutions can be found outside hospitals. For instance, how many primary healthcare centres would be needed around the nation to meet the needs that you see?
It is important that we strengthen primary healthcare. Primary healthcare centres are just one way of doing that, of course. We have got other suggestions as to how we could strengthen primary healthcare. But it's not just primary healthcare, it's also subacute care and aged care. The whole continuum of healthcare needs to be balanced so that we only are using our hospitals for those who really need to be there.
Could you profile one of these centres and explain how they would relieve stress on hospitals?
Well, if one of our comprehensive primary health centres had the ability to do plastering, suturing, minor procedures, had a multidisciplinary team there, then people would know they could go there as the first point of contact, get all their care there, including after hours, and there'd be no need for them to go to hospital emergency departments, and they'd be able to do it close to home.
But how many of them would you end up seeing around the nation? I mean, a city like Sydney or Melbourne, how big a catchment area would one centre serve?
Well, I think it depends on that local community and the density of that community. And, of course, there already are some substantial-sized primary healthcare outfits, 24-hour medical centres and others. But, it would really be up to the local community and the health planners to take that sort of detail on. So we're not specifying a particular number or a particular population size.
But what is the difference between what you're proposing and what the government has already got on train with its so-called super centres?
Well, they're part of the same family of centres, I suppose. The GP super clinics would be added to in our model with some of the community health services that are available, as well as minor procedural centres, radiology, pathology, and also perhaps medical specialist services all housed in the one facility.
When you say in the report that 40% of general practices in Australia still have 4 or fewer practitioners, the implication seems to be that that's not the way of the future, that perhaps that's too small, that big is the way to go. Is that the case?
Yes, look, we're suggesting, obviously there's always room for diversity, but if you have a critical mass of general practitioners and then some other clinicians there as well, such as nurses and dietitians, podiatrists in the one centre, you get a critical mass and you can get all the care you need in one place, and they're working as a team. So even things like having after-hours care is much easier if you have other colleagues who can take various shifts and cover the hours of the day and the days of the week.
The federal government is very keen on the idea of expanding the role of nurse practitioners, but you seem to be saying in the interim report that they should be empowered to take on wider responsibilities in rural areas where doctors are scarce. But apparently the Commission doesn't think they're up to providing the same medical care in urban centres. Is that right?
Well, we've said commencing in remote and rural areas, but obviously doctors can be scarce in other places, and nurse practitioners have roles in different settings, including emergency departments and sexual health clinics. So where a nurse practitioner position exists and where someone is credentialed and competent in those activities, and that's already in place, we believe if they've got prescribing rights or referral rights, they should be covered by MBS and PBS.
You're looking to financial bonus payments as incentives to hospitals to operate their emergency departments and their elective surgery lists more efficiently. Is that what the problem comes down to? Inefficiency? Pay them a bonus and they'll sort it out?
Well, in our report, we also highlight that we need to, again, improve the whole healthcare continuum, primary care and getting people out of hospital when they don't need to be there to help hospitals handle that demand pressure. But part of this is also saying, well, let's create some incentives for the hospitals but make them able to do it by supporting them by getting the rest of healthcare right as well. But
part of the problem isn't chronic underfunding, understaffing, acute bed shortages?
Well, one of the things we've suggested that is hospitals with emergency departments, we know that you need to have a flow through that very busy emergency department into available beds. So we've suggested an additional grant be provided to hospitals with emergency departments to ensure that there's a bed availability at all times. So we are recognising that part of the pressure in busy, big hospitals with emergency departments is that they need to have vacant beds to move people into when they are in need.
Looking at your interim report overall, option A is one where the Commonwealth and states would continue to share responsibility for health. But option B is one where the Commonwealth would be responsible for all aspects of healthcare, delivering services through regional health authorities. How feasible is that option?
Well, in our final report in June, when we come down and suggest which is the preferred option, we'll also be looking at the roadmap of how you'd get there, what sort of process, what sort of timeline, and the logistics of moving from where we are now to an option A or to an option B or indeed to an option C. So that roadmap and the feasibility will be what we're looking at in our final report.
You've pointed out that 650,000 people are on public dental health waiting lists. And you've come up with a dental version of Medicare, including a 0.75% new levy for all workers who currently pay the Medicare levy. Now, what's your thinking behind that? Why is that necessary?
Well, actually, in addition to those people on those waiting lists, about a third of Australians are not getting the dental care that they need in any given year. And what we're proposing here is not the equivalent to an MBS scheme. Just to be clear, there is an increased Medicare levy, but those funds would then be applied to a person's choice of either a health plan with a private health insurer to purchase their dental care in the private sector, or to strengthen public dental services for those who want to go to public dental services. So it is about people getting the choice of and building on the strengths of private dentistry in Australia, as well as building and strengthening public dental services.
I'd be surprised if you're not already aware that the government would be feeling somewhat lukewarm about the idea of introducing a new tax, no matter how beneficial you might argue it is. Is there an effective fallback position for what many regard as an appalling dental health situation in Australia if the government isn't prepared to accept a new levy?
Look, I think it's important to emphasise that new levy is not new household outgoings. The levy would actually be substituting for what people are already paying for their dental care. So they would pay it as a levy, but then they get to select a plan for which their fee for that plan is paid for. So in a way, we're changing where their dental spending occurs. But on your question of is there a fallback, we wanted to float this idea to see what people thought of it. It was building on the strengths of the current system and not about creating a two-tiered public and private dental system, but actually putting the choice with the consumer, with the person and their family as to which way they wanted to go.
Christine Bennett, we look forward to your final report in June. Thanks for talking with us.
Thank you.